I think what I want to highlight here is again the centrality of the tongue. Thank you. So just now what we have done is to give an overview. Then after the overview, we are looking at the infant part, right? As we move along, and then you have children and probably adult with the tongue tie. That's what to deal with it. Okay. So now we're going to still, with this tongue concept in mind, linguadontics, we talk about the origin of malocclusion. Of course, Prof, maybe it's time to get the orthodontist professor in, but he'll kill me rather than. But let's look at this. Yes, there's always genes, genetic influence, 30%, but your behavior give 40%. And the dentist or the doctor is the swing vote, 10%. So you believe that it is all fate, then done. Patient just have to do extraction and then live a life. Or you think there's still a chance, if we change some habits, we can be healthier because of our commitment to it, right? Then you might be able to stand with your patient and contribute to that 50% against the 30%. We went through this, right, thinking that we will map our genome, but but we are no better than the fruit fly or the rice, right? We are just somewhere between with 20 to 35,000 genes. So I don't think it's really the number of genes, but really is the expression. So the phenotypic expression. We have gone through this, our Master of Functional Orthodontics. And of course, the most famous one that we always remember will be Edward Engel, right? So he is the founder of Scientific Orthodontics. And mind you, he practices orthodontic, right, kind of orthodontics. And he talked about it. He was recognizing that orofacial musculature has on the shape of dental arches. Occlusion is kept stable by intraoral and perioral muscles, and mouth breathing was an important factor for class 2 kind of dysmorphosis. We are just beginning to realize how common and varied are the vicious habits of the lip and tongue, how powerful and persistent they are in causing and maintaining malocclusion, and how difficult they are to overcome, and how hopeless in success in treatment unless they are overcome. So this is also a very good paper written by a speech therapist, good friend Linda Donofrio. If I'm not wrong, now she's in Italy. She left US and touring the world. And is malocclusion and acquired craniofacial dysmorphology are the result of chronic oral dysfunction and oral malfunctional disorder. In order to achieve long-term stability of the face, that include the dental arches and teeth, right, it's critical to understand the underlying pathology contributing to mouth occlusion, open bite, high cavity collapse. So mouth breathing is one key. Professor Kristen Gumino talked about it, Stanford pioneering in sleep. He was in Singapore 2017 and he gave this lecture highlighting mouth breathing is not normal and how it relates to malocclusion, frequent infection, phonation, and posture and changes in sleep. So now, again, it's clear to you why this is all about. And the aims for malfunction is to change all this and use the nose correctly. There are also guidelines now looking at the mouth breathing children. And mouth breathing is an etiological factor for sleep disorder breathing during childhood. Mouth breathing, airway obstruction, craniofacial abnormalities are the keywords in here. So you can imagine, mouth breathing, you can get your airway blocked. How? Okay, we'll run through that. So like I say, we used to have this, now we get a combination of all those, right? Why now? Because when we were hunter-gatherers, how we eat, how we work out the body is so helpful to grow the whole body as a whole. And now you can see once you go into modern industrial state, everything starts to collapse, and even the whole airflow chamber is reducing in size. Take note of this arch. Again, you see the wisdom tooth erupting before the ramus, not having to find a restriction in space, right? That's why the uprightedness. And also note all these teeth, how uprighted they are also in the arch. So that's also my whole concept when I'm doing orthodontics. I want my posterior teeth to be upright. They are not, tilting in to make contact. I don't want that. I will create. But the problem is that you can see they can interdigitate quite well, because this is a situation where they bite into rough, grind into position, right, naturally, so that they can fit well. But now if you upright the teeth, sometimes you only get a few cuspal contact, which is not as tight and close. Now I still prefer the vertical transfer of forces through the axial part of the root into the velar bone in order to be ideal for the whole structural system. So you saw this again earlier, and again, all this growth and development is important. So this is Professor Isoko Kondo. Kondo Sensei is a Japanese orthodontist. She is probably the first female. Her license number is number 3, so quite early in the work. So we have an opportunity to hear before she sealed her mic. So she was 80 before she gave a lecture in Taiwan, and it was well attended by almost 600 dentists. We felt this is our last chance to hear her. And true enough, she passed on in 2022, much later, but she has 12 disciples, so I think her work is going to be carried on. So she mentioned very early that yes, in order to get your arches right, you get your tongue and lips to exert the right force to balance out. So if there's any imbalances between the tongue and lips, you can expect movement of your teeth, of course, together with the distortion of the alveolar structures as well.
This book is still available.
Yes, only one print so far. It's during that year, her disciples actually printed another round for her. Yeah, you can still get it probably online. If not, I can check with one of the disciples, Sabrina Hong, and connect with her. Yeah. So the second point that she highlighted is very clear also. Nasal respiration, right, is the key. So this is the part that is highlighted at the other corner. So she mentioned, expand the tongue spaces, develop an upper arch, lower dental alveolar arches, and the removable expander plate or whatever way. I don't use removable plates. I'll explain why. Second point is nose breathing, training with lip closed. I think the key word here is training, right? It's not just a given. You start orthodontic, patient will just close the mouth or put the tongue out. You have to train them, right? No other way. Oops. So frenectomy or now frenectomy, right? Facilitate tongue lift. So it's also highlighted there already. And of course, the other training process to train up the paraoral area. So even as an orthodontist, she also talked about the myofunctional therapy, right? So she started with chewing gum, putting it up to the roof of the mouth. So instead of the myospot, you can use the chewing gum and flatten against the roof of the mouth. We don't have chewing gum in Singapore. You know that, right?
Yes.
Yes. Yeah. You can bring, but you won't get. No, you won't. We just can't sell, but no one get caught or jailed because you have chewing gum on you. Okay, so you can still. We just you look at the train station, right? You know all the chewing gum on the floor. We just also so OCD, we cannot tolerate this kind of sticky thing on the floor. So we decided to ban it altogether in Singapore. Yeah, it's for our train station, really. It's right after we introduced our first generation of the Mass Rapid Transit, MRT for short, right? So we decided not to have chewing gums to mess up the look of it. Yeah, that's how it. Okay, so your tongue up, your lips training, right, and of course some other exercises. And so she went on to demonstrate her point with a case that was followed up for 40 years. Yeah, insane, right? Yeah. So, patient class 2, right, deep bite, intrusive, extracted 2 teeth. Of course, I think if given a choice, she probably won't extract now, but it was just normal then, and I would say even normal now, right? Extraction. And then you can see a very concave profile for many years until much later. Then you see the whole face grew up again. So just now we were talking about the question: is it ever too late? I don't think so, right? So every point, I think if you continue to put the bone under stress, you'll be able to move it. So this is the other paper. Ankyloglossia is a risk factor for maxillary hypoplasia. So Audrey Yun and team, right, also highlighted that if you can lift the tongue, right, your upper jaw is narrow. So to me, your class 2 and class 3 malocclusion all come with a common upper jaw being deficient, right? Because the tongue just can't go up, and because of an upper jaw being small, you have 2 choices: one, to bite into the narrow space, or you just bite forward and you get into your pseudo class 3. Very few patient has really real class 3 skeletal. We have it in our Asian population. Actually, we have a higher proportion of this kind of patient, right? But in the Caucasian, I think not that many. Yeah. And whenever we see the complexity of malocclusion, right, it's so crazy for Asians, right? Yeah. So I think if you have a chance to compare, because Asian morphology is just very prone to airway obstruction. Okay. So one of the papers that was very well quoted, where we even do our sleep training in US, right? It was this paper by our Singapore prosthodontist and ENT, otolaryngologist. Anyway, they were highlighting if you do mouth breathing, but more anything than not, we as Asians we have a more restricted space. So one of the paper from Harvard also highlighted on the sleep apnea correlation chart, being fat, you're not on it; being Asian, you're on it. Yeah. So we are narrow, and again the Americans was treating big fat people, and they snore. And in the same clinic, you have very thin Vietnamese out snoring the Americans, right? So it's not about being fat or it's external. Sometimes, of course, the girth of the neck gets restricted because of this fat deposition, right? From the outside or behind the tongue or around the pharyngeal area. Yeah, but that is still nothing compared to the structural predisposition. So Asian, yes, and there's also another issue called upper airway resistance syndrome. Okay, mouth breathing looks like this when you sleep. Snoring. Then you have upper airway resistance. Then you have sleep apnea, obstructive. Right? Nobody is always OSA. That person will be dead then. So you go through the whole spectrum: mouth breathing, snoring, resistance, apnea for a while, and then you start going back, maybe a bit of snoring, a bit of mouth breathing. So throughout the night, it's always switching between this whole spectrum. But this is malocclusion the Asian way, right? So really tight. Everything is constricted. We have a more what I call sometimes mongoloid kind of a facial structure, We want to grow forward a lot more, right? Because we're narrow, so we want that space. But we have different markers for beauty. We want to look like Caucasians. Then we talk about maybe we should have it flatter, we take out teeth. Then we doom ourselves to a lot of issues. So I think just like our lateral ceph tracing, right? Your lat ceph tracing, Steiner just use one subject, his son, I think, and then determine all the landmarks. So I think some of the papers need to really look deeper into all these different ethnicity differences. I think then we can have different type of treatment plan. But I think the easiest treatment plan for me is not to extract, right? That will be easiest. To just grow everything back up again. So sometimes when we look at this, we say we need to expand. But to me, it's not about expansion. This is about restoration, restore. This is undersized. We're not making it bigger, right? So why is it undersized? The teeth is telling you that. If the size is right, they will be able to stand side by side. No one needs to rotate. No one needs to step out of line, right? So like for this case, you can see that things are erupting, right? We decided to start on Invisalign for a case, right? This is step by step. You can see things changing. A lot of times I don't even put attachments, right? For my cases. Yes, there are some, like most of the time I don't. Right, so we are able to like just move things around like this, grow it, right? So the canine is excluded. Slowly, you can see the space opening up, and the canine is coming in again. All right. So when we do all this intake for patient, be it for orthodontics or anything else, because now I'm tending to see more of the muscle function issues, TMD issues, and orthodontics and sleep, right? So it's not, I need to know, right? Shall I say, I need to know their history. So we ask them a lot on their muscle functions to establish understanding. There are also other forms that we've always been looking around where I think I will collect all these forms and all stuff and I'll send to you all. I can put it on the WhatsApp group, right? So we can check it. So but there's no perfect form. No perfect form. Just whatever you feel that will give you enough information so you can put things together, and then we can run through. Even as a child or even adults, we ask all the way and say, were you breastfed or were you bottle fed? We will ask. And they will tell you, they can remember, yeah, my mom, I'm always on the bottle. Yeah, I did my tongue tie release when I was young. Oh, I had this, I had that, right? So from the early childhood development, you will already be given some information why they are showing up with problems to you right now. So functional therapy, we go through all this. Like this child, she's 9-year-old when she came in. Right, you can see some in-standing teeth, cross-bite over here. Right, the lateral is growing at an angle. When the space is not sufficient, you can imagine the teeth when they're lining up to come through. Right, they're already being orientated incorrectly. So it starts even when they were tooth butt. So we started her on myofunction and trainers. Right, so any trainer, myobrace, myomunchie, healthy start, whatever is available, right? They're all trainers. They're training the muscles. So she doesn't like it for 3 months. You can understand why, some resistance. But as you notice, her teeth are straightening out a little more, right? She's very motivated, and this is her 7 months into the treatment. So you notice, right? If your tongue decides to come back into the position, your tongue can die. There's no orthodontic wires, no plates, just tongue, lips, and correct function all over again. Alright? So that's why I say if we can get this right, introduce it to preschools, young children, mothers are very familiar with lip close, tongue up, nose breathing technique, proper swallow, right? We will eliminate malocclusion by a good percentage. But it's not to the favor of orthodontists. So this boy came in also class 3-ish. Look at the facial form. 5 months of training, and then we decided we want to add the trainer. So this is between here and here is just exercises, and then the other one has an extra trainer to wear. He looks like a different guy, right? Yeah. And we lost that position after he slacked. So for 6 months he didn't come back. He came back, and now we're starting orthodontic treatment for him. Yeah, so I'll compile more information next time to show you his progression. But he slacked and then he went back. Yeah, we were so happy to see that he might just jump the bike already very soon. So chewing, again, you're familiar now. All 12 cranial nerves are involved. So when you chew, your face is moving, right? Your tongue is prepared. You're ready to swallow. You stop breathing. You swallow. There's always out breath when you finish swallow. Try swallow. There's an out breath. Yeah. Then you can resume your chewing, swallow. So all your vagus nerve, your facial nerve, your hypoglossal, your trigeminal, they're all coordinated very intricately. Miss the spot, you bite on your tongue. Yeah. So when we see children not able to swallow, we talk about the perioral, the movement of the neck. But do you notice them blinking their eye like this also? And some of them even do this a lot. Yeah. And the moment you ask them to put their tongue up and slow down the breathing to 10 breaths, 6 breaths per minute. Okay, maybe just do 10. We're usually doing 15 now. You can check your phone, your watches. Sometimes they'll tell you how many breaths you take. 15, 18. Yeah, we should bring it down to the single digit if you can. Alright? Like me, talking is bad for health. Right? I'm just gasping for air all the time. Talk, talk. Yeah, so I'm not really breathing properly. So after one day of lecturing, yeah, I'll get really high, adrenaline pump, because you're just always out of breath, your heart rate goes up, your blood pressure goes up because of talking. Yeah. So lecturing is a very dangerous job. Yes. So what you want to do is orbicularis oris. You want to train it up. The reason is because if you can close the mouth, then it's good. Okay. So this is the other tool. This is the munchie. We don't have munchie. Okay. So now the good part is that they have developed one that is good for a 6-month-old. So what about Mary Burke? She's second generation. First generation, Dr. Kevin Burke actually invented this as a toothbrush. And when he gave it to his patient and family, teeth got straighter, face got big, nicer. So he said there must be something to it. So that's how he developed this further. Chris Farrell joined him, learned something, and then broke out to start Myo Brace. Right, that's how the two things got going in Australia. Then in US, I think we have a healthy start. Right, I think there's many more. So we are hoping that this will go to market soon, right, on mass scale, so that we can have a replacement for pacifier. Instead of suckling, pushing the tongue down, right, we have this, chewing, coordinate your facial, coordinate your trigeminal, coordinate your cranial nerves, right, to allow the tongue to still elevate. So like this boy, when he first came, right, he can't close his mouth. You can see the mentalis muscle really tight, trying to close his mouth. So we get him a trainer, bite, chew, practice 5 minutes a day to 15 minutes a day, right? Train. So sometimes you get parents to get a video and ask them to just record themselves chewing, swallowing, and this will really be helpful for sometimes tongue thrust patients. Okay, when you need to swallow with the tongue thrust, you need space in front. But when you have this thing blocking you, they can't complete the tongue thrust, they cannot complete their swallow. They can't complete their swallow, they accumulate saliva and they can't breathe because they haven't completed their swallow. And what's next? They want to get out. They take the thing out, they spit the saliva or they swallow later. So you know there's a problem with the tongue positioning. We get them to wear this and help them to understand you can actually put the tongue above to swallow backwards, right? If they figure that out, yeah, then you have that whole pattern developing already. So this is him about 9 months later. You see, no problem with extension. So he was from Poland, so we couldn't have time to do this release for him. He went back home to do it in Poland. This girl came, actually she's family, one of my distant niece. She had to do adenoma and tonsillectomy because she stopped breathing at night. And the doctor say that she has sleep apnea, must do the surgery. I did the surgery, same thing, go back. After a month, she's snoring again. Yeah, as long as you don't change the habit, you cannot resolve this problem. And there's a paper that's talking about it, I'll show it to you later. This girl, I took away her pacifier, immediately gave her this as a replacement, and you can see she's actually chewing and she's sticking onto it. She's holding it on herself. And this special need boy, same thing. We need to get him to close his mouth. Yeah. So this is one way that we can repeat and repeat so that he can learn. Yeah, because sometimes giving full instruction is not easy. And then my nurse's son, so yep, we also start early. She knows the consequences. So yeah, instead of pacifier, change this out, right, and do this early. So we really want to put the tongue up, put it to the roof of the mouth, and you can see how the tongue can exert its space, right, strength into developing the space for it to puck above. And then that's how we widen up the arches, right? So again and again, you can see the centering of that whole line, upper lower jaw. Sometimes you see a deviation of the jaw. You don't know where is the center. Should you do orthodontics based on which line, which is the center? Get the patient to put the tongue up, you'll be able to have a good idea. So sometimes what I'll do is I will get them to bite into the neutral position, and other teeth might be out of position. If you understand what I'm saying, this is a good position. This is drop. This is the center position, but you have open bites or lateral open bites. Then I just still use that as a reference, scan in the bite and move the teeth accordingly and reach that spot. So, yep. So this is a class 3 case. So it came to us, teeth are still rotting. So this is him about 3-4 years later. So you can see that we have the opportunity to redirect growth, right? As long as the patient is compliant and understand that they have the full control. So the discussion is always very clear. Do you want to do it? Not I want to do it. If you don't want to do it, let's call it off. Because I don't want to chase after them, I don't want to chase after the parents, and I don't want the parents to chase after me, right? So if you don't extract, where are you going to find space, right? So I still remember doing this, having this conversation, and one orthodontist from UAE was telling me, right, I don't want to put my reputation in my patient's hand, which is true, because you're going to leave them to decide whether you're going to achieve the results. But of course, we provide the system to help them out. So he has tongue restriction, he has lip restriction, all those things we cleared for him, right? This Wolff law saying that really, if you can put load to the bone, you are going to grow things again, right? So literally, this is what we have, the regional acceleratory phenomenon, RAP for short. This line was drawn across to the, let me just call out that word for just a moment. regional acceleratory phenomenon, RAP. So literally it's like micro trauma. So every time when you start your work on the orthodontic component, yeah, and there was a discussion, 0.25 mm is the distance between your, there's a distance of your periodontal ligament space, right? So you exert that, you get a response, the body rebuilt, right? And then in the wake, some things is being taken up by the osteoclasts, yeah. So then you clear the path for the movement. So you can see the line drawn across the premolar, right? So through the premolar, everything above it is redeveloped by the patient, right? Putting the tongue up. And of course, this whole process is also when we are doing some orthodontics. But she's still young. She's only 14 when she started. Probably on her own, she will also have enough of this growth factor that will see her through to the end point if she continues to put her tongue up. But with the orthodontics, I feel it's going to accelerate the whole process. You can see the mid face developing year on year, and you can imagine how much that maxilla is getting bigger and the whole pyramid of bone above it, right? So not only just we get the facial, but I think we get a very nice, like say, overall growth and development. Okay.
We mostly it's similar to functional regulators such as twin blocks, Paglietta, Frankel's functional regulator.
Yes, I think the European side of things, right, has developed all these functional appliances for many years, and that's why East Coast of America also practice quite a fair bit more of the functional orthodontics. Then the West Coast, yeah, then they do more of the mechanical. But we're glad that at least now with the aligner therapy, we can also incorporate functional correction more easily into the system. Okay, I think we're just in time for lunch. Thank you.
Have you heard about iCuro? It's a mouth shield that you use for, actually I think this was invented to treat stroke patients by pulling outwards 10 seconds times three times a day. And they got so many different improvements in the whole body. So we started treating patients while they were still under anesthesia of the brain surgery, with the nurse holding the lips and dragging the appliance up. And they followed the patient, and from not being able to stand on their own, they could walk. And the treatment was only this oral appliance. And now they're saying that it could be good for snoring and other things. So.
I think it's the same principle.
Yeah.
It's the whole fascia that we are releasing, and in Japan also they talk about also working from the foot up. Sometimes you see the toes that are adapted wrongly, and just by doing some footwork, they're also able to get the person to stand straighter and all. It's a two-way traffic, right? So there's no like this will sort everything out, but also just wearing orthotic for your shoes is not going to level off your hip. You're just continuing the problem, right? So the hip is uneven. You put something in to keep the hip uneven. So you can walk flat, but it's not ideal. So we're trying our best to, like say, look at some parts. So I get interviewed by my work, should I say body worker or physiotherapist, chiropractor, osteopath. They have a very clear understanding to work up to here, and they talk about all the compensation. And very quickly they will blame the patient for being on the phone, being on the computer, right, the lifestyle. But in their psyche, they're not thinking hard about the airway component that is there, right? So they're not looking at say if there's an airway component, right? How the patient will react. Yeah. So to me, I feel if we talk about air and breathing, we prioritize it no matter over everything. Yeah. you must give air first. If you can't, everything else you do for the body is not going to be stable. Yeah, the body will compensate again. So we do everything, and as a dentist, I think we're in a very good position to give volume to the space. Yeah, from the structural to the functional. Yeah, we're in good position. Better than even the ENT. Sometimes they can do surgical clearance, opening up the space, but if the tongue is still low, it's still low. Yeah. But it will be interesting to find out that instrument again. Yeah, IQ.
IQORO.
How do you spell?
IQORO. IQORO.
IQ. Okay. We'll look up.
Jason, Grace son, I think she's lecturing with Professor next month. She's American, yes. She's got a lot of PDM campus. PDM. Grace son. Grace son. You're talking about.
Grace son as
Grace son.
photobiomodulation. Yes.
Probably you're talking about that from America. Right?
This is a Swedish version.
Swedish.
So-
So it's also called IQ Oru. There's a flash names. Maybe similar names.
So I told
Yeah, more of PDMs. Probably Janet is talking about something
Professor, we are ready for lunch.
okay, we go for lunch. Let's go.